Hello, I'm Steve Messenger, the Policy Director for the Nevada Primary Care Association, and this is Health Policy for Health Professionals. So today we're going to talk about why do health professionals need to understand government, the Constitution, the U.S. Constitution, the Nevada Constitution, a rather lengthy timeline of health policy developments, how a bill becomes a law, how a bill becomes a law in Nevada, federal budgeting, Nevada budgeting, advocacy, and my little soapbox. So why do health professionals need to understand government? Government pays about 2/3 of health expenditures through health insurance coverage, either through programs like Medicare or Medicaid, also the Children's Health Insurance Program, the VA, and then other investments in health. Another 3% of health expenditures are spent on public health. So why do health professionals need to understand government? Health is becoming an ever-increasing concern of government, with health expenditures growing at a pretty steadily rate over the last 50 years. As a percent of our total gross domestic product, health expenditures have reached about 18%, forecasted to go to about 1/5 of all our production in the United States within the next decade. So why do health professionals need to understand government? As far as the federal budget goes, you're talking about more than 1/5 of spending just on Medicare and Medicaid. That does not include other investments and other health programs that don't flow through those programs. So we're already spending a significant portion of the federal budget on health. At the state level, you can see that Health and Human Services make up the largest portion of the state budget at about 40%. Medicaid alone makes up about 29% of state expenditures. And then if you're working in a hospital system, what does that look like for you? Well, government's going to be paying for about 2/3 of your patients, 45% through Medicaid and about 45% through Medicare and about 21% through Medicaid. So your payments are coming largely from government. So what is government? Starting at the beginning. The Constitution was ratified in 1788 and enacted in March 1789. This was the product of an intense discussion about how to balance the needs of a strong federal government and the desire for states' rights and a weak central government coming from the experience of being under a monarch in England. We're also talking about the need to balance power between small and large states, and also dealing with the compromise of how to deal with the slave states. So the Constitution is really characterized by checks and balances and separation of powers. That means that each part of government, which is divided into 3 branches, has to rely on inputs from the other parts and have veto power or checks over those other parts. The 3 parts of government are the legislative branch, the executive branch, and the judicial branch. You can notice in the preamble of the Constitution, we the people of the United States, in order to form a more perfect union, establish justice, ensure domestic tranquility, provide for the common defense, promote the general welfare, and secure the blessings of liberty to ourselves and our posterity, to ordain and establish this Constitution for the United States of America. When we think about health policy in the United States, a lot of it is coming under that command to promote the general welfare by the Constitution. So the first thing that the Constitution does is lay out the structure of the legislative branch. This is Article 1. The legislative branch is split up into 2 chambers, the House of Representatives and the Senate. The House having 435 members and the Senate having 100. In the House of Representatives, the average congressional district has about 700,000 constituents, and that changes every 10 years with the census, so it'll change again next year. In the states, California has the most representatives with 53. So 7 different states have only 1 representative because they have low populations, and Nevada has 4 representatives. These are all 2-year House terms. In the Senate, each state has 2 senators, and they're voted in by the entire state as opposed to the House, which is voted in by the 700,000 people in their congressional district. Senators serve 6-year terms. One important key to the legislative branch is that all bills for raising revenue, that is increasing taxes or making new taxes, shall originate in the House of Representatives. So the checks and balances of the legislative branch. The congressional Congress has power over the executive branch through taxes that they have to authorize. The executive branch can't start new taxes. They can't start new programs without a statute to authorize those programs. They can't declare war without congressional approval. And then Congress can also pass a bill that the president has vetoed with a 2/3 majority vote. Also, Congress may impeach the president and remove them from office. Conversely, the president or the executive has power over Congress through the veto that they can stop laws that have been passed by Congress. For the judicial branch, Congress has powers to appoint, to authorize or confirm appointees to the Supreme Court. That happens in the Senate. And those judges can also be impeached by Congress. That happens not just for the Supreme Court, but all throughout the federal court system. And then conversely, the judicial power over Congress, the judicial branch can always determine in their judgment that a law passed by Congress is unconstitutional. The executive branch is vested in the President of the United States. The Constitution has been amended so that the Vice President is elected with the President. One of the most important functions of the President is as Commander-in-Chief, meaning that they command the military. The President also appoints a cabinet made up of the secretaries of various federal departments. For example, in our interest, the Department of Health and Human Services. The President checks Congress through the veto power and chooses appointees to the federal courts, but can also pardon and commute federal sentences. And then the President is checked by the power to override, Congress's power to override a presidential veto. And the courts can block executive actions. So we talked about the Department of Health and Human Services. These are some of the agencies under the Department of Health and Human Services that you might encounter in your career. AHRQ is the research division agency for healthcare research and quality. The Centers for Disease Control, the Centers for Medicaid and Medicare Services are administering those payment programs that we talked about. The Food and Drug Administration deals with food safety as well as approving drugs. HRSA, the Health Resources and Services Administration, is over community health centers, over loan payment programs such as the National Health Service Corps. The Indian Health Service runs its own set of clinics to deal with tribal populations. The National Institutes of Health is primarily a medical research institute. And then SAMHSA, the Substance Abuse and Mental Health Services Administration, distributes mental health substance abuse grants. The judicial branch is most visible in the Supreme Court, and there's a whole system of federal courts that we won't be getting into today, but I wanted to bring some examples as to the kind of effect that the Supreme Court can have on health policy. So the first is Chief Justice John Roberts' decision in the law that essentially decided for now whether the Affordable Care Act was constitutional or not. What the court found was that the Medicaid provision, forcing states to expand their Medicaid and threatening them with taking away traditional Medicaid if they didn't, that was unconstitutional, and states would go on to have the right to choose to expand Medicaid or not. The other thing that they did find is that the individual mandate, because it was a penalty for an action taken or not taken, could be considered a tax and therefore was constitutional under Congress's power to tax. Today we have another court case against the Affordable Care Act that threatens to overturn the whole thing. Basically what happened is that Congress had eliminated the penalty for that individual mandate, and so now there's a question as to whether Congress's power to tax and to enact policy through that power to tax would still extend if that tax was zero. Nevada's Constitution is it's very special and has a great story behind it. The Constitution became effective on October 31st, 1864, right in the middle of the Civil War, which gives the state its nickname, the Battle-Torn State. And our Constitution was sent to DC by telegraph. At the time, the longest and most expensive telegraph ever sent, in order to secure statehood days before the due date would help ensure President Lincoln's reelection the following couple weeks in November. So in Nevada, the term for senators is 4 years. The term for members of the Assembly is 2 years. And there's some key provisions that make dealing with the Constitution in Nevada a little more difficult. The first is our legislature only meets every 2 years. It's one of only 4 states in that situation. Our legislative session is only 120 days, which means it is a race from beginning to end. It is a citizen legislature, which means that the legislators, they don't get paid enough to be full-time legislators. They all have to have normal jobs, and this is just a small part of their total life. Both houses have a term limit for 12 years. The Constitution says a bill or joint resolution which creates, generates, or increases any public revenue requires a 2/3 vote in both houses. This makes it very difficult to raise revenue, except in dire times or extremely one-sided electoral advantage. However, if only a majority is received in both houses, the bill does go to a vote of the people in the next general election. That's generally going to be at least a year and a half away. In Nevada, the governor serves up to 2 4-year terms. He has a veto power, but that veto may be overridden by a 2/3 vote in both houses, just like Congress. And because of the short legislative session and the every 2-year schedule, there is a provision for a special 20-day session which the governor can call. The bills in that session are only limited to the issue that the governor opens the session for. The Constitution says that taxation, personal income tax may not be enacted, neither may inheritance tax. There's long been a special provision of not taxing warehouse inventory, which has made that an important industry since the beginning of the state. As a mining state, there's important protections for mining. They can only be taxed at a maximum of 5% of net proceeds. However, there's no more detail on that clause, so it allows mining companies to, deduct most of their expenses. And the actual effective mining tax on the gross proceeds in 2018 was about 0.6%. Also, a special provision in the Constitution that no money may be appropriated by the legislature until the appropriation for education is complete. That's the first of the appropriation bills that must be passed. And then as far as amending, it takes a long time to amend the Nevada Constitution. However, we see constant efforts to do it throughout the history of the state. One reading says that the current Constitution has been amended over 103 times. In the past several years, 12 constitutional amendments were adopted by voters out of 22 proposed. So basically every legislative session, there is something moving through the legislature that is a proposed constitutional amendment, and at every election, we expect to see 1 or 2 on the ballot. So in order to understand health policy, I think it's important to understand where we came from. And we're going back pretty far for this, but I think that it's good context for understanding what we want to do next and the situation that we have find ourselves in now. So in 1798, President John Adams signs the first public health law. This was in response to a cholera outbreak coming from sailors. And in order to address this outbreak, they established a per capita tax on sailors entering U.S. ports. And they used the proceeds from that tax to fund hospitals that would be able to treat the cholera patients. This system of hospitals became known as the Federally Administered Marine Hospital Service. Almost 100 years later, we're starting to see social insurance take place in Europe. German Chancellor Bismarck implemented the first national insurance program for industrial workers. The health program came actually after more of a workman's compensation program. But the whole idea was the same, was that the government was going to take fees from workers as well as their employers and add in some government taxes and be able to finance health care for people who ended up getting sick. A few years later, we're starting to see science play a big part in the advancement of health policy. Health policy has to get more and more complicated as medicine gets more and more complicated, and the expenses come with both of that. So in 1887, the Marine Hospital Service opened its first microbiology laboratory and was able to visualize the bacteria that was causing cholera, which allowed for a much faster diagnosis. Soon after, you're starting to see the private sector get involved in health provision. And so in America, where this isn't a government-led effort, lumber companies in Washington state are starting to pay doctors full-time to stay on staff and provide care for their workers. That system becomes known as Blue Shield. In 1911, Europe moves forward with more national health insurance in the United Kingdom. They passed the National Insurance Act, establishing mandatory unemployment and health insurance. And they kind of started the idea of a decentralized administration system. They had an existing system of social clubs that were selling, they called funeral insurance, now we call life insurance, but basically insurance that would just cover the cost of your funeral. That existing system was on top of other companies that were insuring the financial system. And so the UK government developed a program which would allow both of those streams to broker the health insurance and administer it. We would end up taking a lot of ideas from that as our health system developed. The next year, Teddy Roosevelt's campaigning for president against the incumbent Republican President Taft and Woodrow Wilson, the Democrat. This is the famous Bull Moose Party. And health insurance, national health coverage was an important part of his progressive platform. He said it's abnormal for any industry to throw back upon the community the human wreckage due to its wear and tear, and the hazards of sickness, accident, individualism, invalidism, involuntary unemployment, and old age should be provided through insurance. This should be made a charge in whole or in part upon the industries, the employer, the employee, and perhaps the people at large to contribute severally in some degree. So this is really the first call in the United States for national health insurance. Soon after, the American Medical Association announces that they support this idea, but very directly after that, they reverse course and they begin a very almost century-long opposition to national health insurance, primarily concerned around the loss of autonomy for doctors. They're talking about how exactly what would happen, that if you set up these systems that are trying to be efficient, that they're going to end up having to tell providers what they need to do and what they're expecting for their money. In 1929, we have Blue Cross, founded in Dallas, Texas by Baylor University. It was an effort to try to stem the uncompensated care that they were experiencing in their hospital, the same story that we're hearing now. They were able to put together a payment package, basically, and sell it to a teachers union that would provide constant revenue for the hospital and guaranteed access for the teachers. At the same time, science is making an even bigger break. We start to have anesthesia, which allows surgeries to get much more complicated. So again, health care is getting more and more expensive because we can do more and more complicated things. In 1934, we have our first president laying out a goal of achieving national health insurance. And he starts off his presidency with a committee to study the options. At the same time, he's also fighting for all the other New Deal programs. So he's got Social Security in mind, he's got work programs in mind. And basically, the committee came back already at a deadlock. This was going to be a contentious issue. And you're hearing a lot of the arguments against socialized medicine. Healthcare gets very political at this point in the midst of World War II, or the beginning of World War II, in the midst of the rise of communism, basically. This becomes an important ideological attack against national healthcare. And so ultimately, Roosevelt drops the healthcare proposal from this New Deal. In the 40s, we're in the midst of World War II, and famously, in a huge determiner for how the health finance landscape would turn out in the United States, the U.S. government froze wages. Now, they did this because they're trying to keep their costs down. They basically have all of industry nationalized, and they're buying everything that's produced for the war effort. So they're trying to keep their costs down. They also don't want any industries that are not nationalized to be taking those workers out of the war effort and into that other private industry. And so they're going to freeze wages. Now, in response, the private companies, in order to lure the most valuable workers, they can't offer a higher wage, so they begin offering health benefits. And this continues today. In fact, it would eventually be codified in law that they would get benefits for those. At the same time, you're starting to see some models of more advanced healthcare. You have Henry Kaiser. He operated a huge steel industry, and he was getting all these government contracts and having to employ thousands of workers, for example, on the Colorado Aqueduct and the Kaiser shipyards. So he contracts with a doctor who basically starts administering his own hospital system to serve Kaiser's workers. This goes on to become open to the public, known as Kaiser Permanente, and we still have that system operating in several states today. In 1945, we see the war over, and we see President Truman come into office. He actually makes FDR's national health insurance proposal one of his main planks, and it becomes a big topic of discussion in Congress again. Again, the American Medical Association goes to battle against it, and they end up beating Truman's party in Congress in the election that year. 2 years later, President Truman runs for re-election again against the arguments of the physicians and for national health insurance, and he wins decisively. The American Medical Association responds with the most expensive lobbying campaign in history, decrying Truman's plan to socialize medicine that would lead to communism. In 1951, we have some regulatory changes that allow for-profit insurers such as Aetna and Cigna to enter the market, opposed to the Blue Cross and Blue Shield model. The Blue Cross and Blue Shield was a nonprofit model that was guaranteed open to anybody. And Aetna and Cigna really found that their business model, they could return a profit to their shareholders if they only selected healthier enrollees who were unlikely to use their benefits. This is the time when the IRS determines that employers can write off the expense of employee health insurance. And so it becomes employers are going to lose less than $1 by financing health insurance because they can write that off as an expense than they are by putting it into wage. And so this begins the growth of the cost of health insurance, and the will initially lead to the stagnation of wages as those health insurance costs rise with the cost of actual health care and absorb all the excess productivity. In 1957, we have the bill that would become Medicare proposed. It was initially aimed only at the elderly because that was felt to be more politically palatable. That was a lesson learned from Social Security, that accusations of socialism were a lot less when you talk about folks who nobody expected to be taking care of themselves and who everybody was expecting to reach a point in their life where they couldn't. In 1958, you have a huge election of progressive Democrats. They are elected largely by promising to support Medicare and with the support of organized labor, which is very much behind this plan. And then 2 years later, you have John Kennedy running against Richard Nixon on the Medicare plank, and he wins. In 1962, President Kennedy gives a huge speech, nationally televised in Madison Square Garden, and he calls for Medicare. And again, the American Medical Association ramps up its opposition. This is a famous recording featuring Ronald Reagan on an old record speaking out against socialized medicine. In 1963, President Kennedy is assassinated, and President Johnson promises to pass Medicare as part of his civil rights package. However, he's blocked by the chair of the Ways and Means Committee, a conservative Democrat, repeatedly refusing to allow a vote. the next year, an even more liberal Congress than any since the New Deal was elected, and this was associated with the loss of Barry Goldwater. 1965, we finally get Medicaid. This was a compromise between three different factions. You had the bill for the elderly. You had a Republican proposal for how do we get private insurance that's premium-based and requires some, the skin in the game. This is Medicare Part B, which is basically your physician services. And then you also had an even more progressive idea that was to get health insurance to the poor. There was an already existing program, but this package expanded that into what we now know as Medicaid. The final vote was 313 to 115, so that was a very effective way by combining the three bills of building a coalition. We're still working under the 1965 Medicaid and Medicare Act as the basis of much of our government-run healthcare. 1971, we're starting to get proposals by Senator Kennedy for a universal national health insurance. In response, President Nixon offers a plan that would get to universal coverage. It's based on an employer mandate. There's a real debate at this time over what the proper level of cost sharing is. How much should the government do? How much should the beneficiaries do? And if you put it on the beneficiaries too much, does that make it worthless? So this is a debate that's still going on today. We've not kind of taken that next step. 1972, we do expand Medicare. Since we can't agree on anything else, we do cover disabilities and severe kidney disease. Another legacy policy that's still with us and still governs health insurance today is the 1974 Employee Retirement Income Security Act. This basically was about regulating pensions, but in the process, it also put regulations, federal regulations, so taking these away from the states on self-funded employer plans. And so in Nevada, many of the casinos are self-funded, many of the miners are self-funded. It's an important regulatory scheme for a good chunk of the insurance. We get to the mid-'80s and we see the passage of the Consolidated Omnibus Reconciliation Act, better known as COBRA, which allows you to keep your employer insurance while you're between jobs if you're willing to pay for the whole premium. You also see the Emergency Treatment and Labor Act, or EMTALA, which requires emergency departments to stabilize patients regardless of insurance or ability to pay. And then in 1991, you really have the subject of healthcare reform coming up in another election. You have the Democrat primary where Bob Kerrey is proposing a single-payer system, and Bill Clinton is really looking for a moderate counter to that, where he thinks he can pull in some more conservative votes. So he talks about a choice for employers to provide coverage or pay into a government-sponsored plan. And then after more development, he later adds a system of regional managed care that the business community signs off on, and this becomes known as the middle way. Clinton is elected, and as he starts his term, a task force led by Hillary Clinton came together and put together the final plan. The president gave a big speech, and then they took the whole thing on a bus tour around the country. This was countered by a very vocal rise of right-wing radio and rise of general anti-government sentiment that seems to come up with every proposal to expand healthcare. And once again, you see the most expensive lobbying effort in history trying to prevent the Clinton plan from going through. The next year, the Republicans win enormous majorities in Congress, and Clinton abandons the whole health reform proposal. They do, again, every time one of these large proposals gets abandoned, they kind of shore up something. In this case, it was the 1996 Health Insurance Portability and Accountability Act, known as HIPAA, another important regulatory scheme under us today, or over us today. Features of HIPAA, there's rules for when insurers had to cover pre-existing conditions and when they did not. This is all about if you keep continuous coverage, then your next insurer has to take whatever you've got. But if you break your coverage, that's when you're subject to to rating plans where you may or may not get covered for certain conditions. It defines protected health information and establishes the privacy rules, standardized transmission forms, the security rule, and the notification rule, which are standard features of any physician's office today. Also regulated medical savings accounts. In 2003, President Bush signs the Medicare Prescription Drug Improvement and Modernization Act. This is the prescription benefit in Medicare, known as Part D. And this came after a long debate on a patient's Bill of Rights pushed by Senators Kennedy and McCain, which did not go anywhere, again, blocked by the American Medical Association and the pharmaceutical industry. By 2006, you have Governor Romney implementing the basis for the Affordable Care Act, a model that was rolled out in Massachusetts. And then 2010, President Obama signs the Affordable Care Act after a lengthy debate about what would go in it. So I'm going to go over a few of the things that rolled out in the year that they rolled out, features of the Affordable Care Act. So the first year, you had pre-existing condition exclusions banned for children under 19. We stopped cancellation of plans midterm. It used to be that plans could determine, oh, if you got this cancer, it was because you didn't disclose this risk to us, therefore we shouldn't have had to cover it. That was over. We ended lifetime limits on coverage. We gave small business tax credits to give their employees insurance. We defined essential health benefits, the minimum package that a plan must have. We established research arms like the Patient-Centered Outcomes Research Institute. We required plans to allow young adults to stay on their parents' plan until age 26, expanded programs to encourage primary access like loan repayment and scholarships. We increased Medicaid federal matching funds to the states so that they would be able to reinvest those funds into health. We expanded the 340B program, which is an important source of low-cost prescription drugs for safety net providers. We expanded the Community Health Center program. We promoted home and community-based services in Medicaid. This is about long-term care. And we established the Prevention and Public Health Fund, which is an important funding source for state public health agencies. Next year, we closed the Part D donut hole, which required seniors to pay very high out-of-pocket costs once they reached a certain cap before they got to the next tier and the coverage would kick back in. We established another research arm, the Centers for Medicare and Medicaid Innovation, which sets up payment model reform. We set up the health insurance exchanges, which would go on to be the individual market. We invested in graduate medical education. We raised Medicare rates for primary care by 10%. And we required the insurers to cap their profits, and any profits over those caps would have to be returned to the beneficiaries. 2012, we started rolling out quality programs in Medicare, and this is the year that the Supreme Court rules that the individual mandate is constitutional, but Medicaid expansion must be optional. 2013, we increased money to states to raise Medicaid primary care rates. We expanded CHIP. We started our taxes for employers who don't provide coverage. We began requiring guaranteed issue of health insurance. Guaranteed issue means that costs can only vary based on geographic area and family size. And then there's limited, as in they specify how much variation is allowed for age and tobacco use. The exchanges and tax credits begin. So this is the first year of healthcare.gov, and the rollout does not go very well, but we do get the exchange open. This is also the first year of Medicaid expansion. So now it's available for the first time to childless adults up to 133% of the federal poverty level. And there's a generous federal match to encourage states to take that up. Nevada's Governor Brian Sandoval was the first Republican governor to expand Medicaid. And today, almost 250,000 residents have benefited from that expansion. This is the beginning of the individual mandate where you're required to have health insurance or pay a penalty for failure to do so. And in conjunction with all these new access to health insurance, we're starting to cut back the ability the other programs that pay hospitals for uncompensated care. Because not every state expanded Medicaid, this ends up becoming a big problem in the Affordable Care Act. In 2015, we passed MACRA, the Medicare Access and CHIP Reauthorization Act, which revises how Medicare rewards providers for quality and sets up new payment and quality incentive structures. 2016, we have the 21st Century Cures Act. This invests in the National Institutes of Health. This is in conjunction with Vice President Biden losing his son and all the national attention going towards cancer, so we call this the Cancer Moonshot. So this is really about investing in research, investing in expedited FDA approval for drugs. The same year, Donald Trump is elected, along with Republican majorities in both houses of Congress on a promise to repeal and replace the Affordable Care Act. This is also the year that the uninsurance rate hits a low of 8.6%, which is still its lowest point in the country today. In 2017 is the year of repeal and replace. The House Republicans pass an Affordable Care Act repeal bill, and the replacement is built around tax-free health savings accounts and block granting Medicaid to the states. The Senate famously fails to pass a bill at about 1 in the morning when Senator John McCain, dying of brain cancer, votes no unexpectedly. Throughout this process, Senator Heller from Nevada was considered to be one of the 3 most likely senators to vote no, but in the end, he does end up supporting it. Also that year, we do pass the Tax Cuts and Jobs Act, which is the big tax cut that ends up setting the individual mandate penalty at $0. We mentioned this before. That leads to a constitutional question. Does Congress still have the power to do all the things they were doing based on a tax if that tax no longer exists? That question is still open. 2018, the administration chooses not to defend the Affordable Care Act in Texas versus Azar. That's that court case. Instead, they're actually in agreement with the Republican attorneys general that the Affordable Care Act is unconstitutional. Attorneys general from Democratic-led states end up winning the right to defend the law, which has been ruled completely unconstitutional in a lower court. If that ruling were upheld, it would overturn all the provisions that we just went through in the law. This same year, the Centers for Medicare and Medicaid Services begins approving Medicaid work requirement waivers. So we have several states that have tried to implement requirements that Medicaid beneficiaries have to prove that they're either working or students or putting in community services in order to receive benefits. Executive orders to expand non-Affordable Care Act compliant plans. These are known as short-term limited duration insurance. They were originally intended to be gap insurance that now can go for a year and more. Also association health plans that are pulled together by chambers of commerce or other associations, but do not have to comply with the essential health benefits. The same year, the election, again, largely fought over healthcare, gives the House to the Democrats, and at the same time, Maine, Kansas, and Utah vote to expand Medicaid, even though their governors have not done so for the past 4 years. Also this year, next session. How a bill becomes a law. Time for something completely different. Back to the Constitution. Bills are first introduced, that means made official, by a representative or senator in their respective chambers. So they put it out there, it gets filed, it gets read into the record on the floor. That's the reading of the bill. As soon as the bill gets read, it's typically assigned to a committee to decide whether or not it can move forward. In the committee, the bill is debated and amended. The committee chair has a lot of power to ignore the bill, so if the committee chair isn't interested in that bill, then it just goes to committee and that's where it stops. There's not a whole lot of ways to resurrect it. The committee chair can also propose to basically replace it wholesale or to change the entire purpose of it. Once it does pass a committee by vote, it's considered reported to the floor, and then it goes to a vote of the entire body. but only if the leader of that body chooses to. So the Speaker of the House and the Senate Majority Leader basically have the choice whether they want to bring a bill up or not. This ends up largely determining what the agenda for Congress is what will both, the only thing that can pass is what both Speaker and Senate Majority Leader will agree to bring forward. So if the bill does get a vote and passes the chamber, it's referred to the other chamber where the process begins again. It goes to the committee, it has to get through the committee, passed out, reported to the floor, and then House votes take a simple majority. Senate votes to pass policy bills are subject to a filibuster, which requires 60 votes to begin debate. So if 60 senators, or if 40 senators choose to not support the beginning of debate on the bill, then the bill does not get a vote. Should be noted that the filibuster has been changed a lot in recent years. They have abandoned it for the approval of federal judges, cabinet officials, and agency appointees. And there's a big discussion as to whoever wins power of the Senate next year, would they continue this rule? This is a Senate rule, not part of the constitutional law. The Senate also has a special rule for budget bills called budget reconciliation. It can be invoked to allow passage with a majority vote. This was used to pass the Affordable Care Act and the Tax Cuts and Jobs Act. So it's pretty common in modern divided government to put bills into the special procedure that they're required to follow to get budget reconciliation and pass the Senate with 50 votes. Any amendments are made as the bill passes through the committee and off the floor of the second chamber, and there's opportunity for amendments in both places. Then the originating chamber can either choose to pass the bill as amended, or they can choose to pass their own bill, pass the bill that they passed before. Then they send it to a conference committee where the committee has the power to vote the final bill out, but basically it's an up or down vote on either floor. Once a bill is voted out of both chambers, it goes to the president to be signed into law or vetoed. If the president fails to sign a bill within 10 days, the bill does not become law, known as a pocket veto. If the president does sign the bill, it becomes law, and it begins being enacted on the timeline that's spelled out in the bill. If the president does veto, Congress can override that veto with a 2/3 majority vote. And a new law may have to go through complicated regulatory development in order to be enacted, a process that can sometimes take years. So the example of the Affordable Care Act was passed in 2010. It takes about 4 years to be completely implemented. So in Nevada, the process is largely the same. You go through committee, to the House floor, to the opposite chamber committee, to the opposite chamber floor, and then either through agreement or reconciliation on that final bill. However, Nevada does have some special features that make the whole process have a few more obstacles, I guess. The first choke point is the limited number of bill draft requests. We call them PDRs. They're allotted to each legislator. They also go to interim and session committees, party leadership, and legislative administration. Most of these have to be submitted before the session starts. A lot of them actually have to be submitted before the November election in the year prior to the session. We mentioned citizen legislators. They don't have the resources to individually employ staff. They each get one scheduler who might act as a good research aid, but they're not legislation drafters. This work is all done by professionals at the Nonpartisan Legislative Council. So here is half of the chart that shows the PDRs. You can get the rest at the link below. But you can see incumbents get a certain amount that are due long before their election. They get a handful along with the newly elected members between the election and the beginning of session. And then you can see that there's 60 total PDRs for each chamber. They get allotted among the committees. And then leadership also gets a certain amount, as well as emergency requests. So the schedule for the Nevada legislative session, remember we're going to 120 days. So by day 15, just over 2 weeks in, the BDRs are due out of committee. That's the total of 60 for each chamber divided among the various committees in that chamber. They must be approved by a majority of the committee, and then those committee BDRs are typically the ones that are proposals from the executive branch. Also local governments and state courts get a say in those. By day 43, the individual legislators' bills have to be introduced on the floor. You can see that that's basically just one for assembly members and 2 for senators. By this time, almost all the individual BDRs have to be in. By day 50 is the last day for committee and leadership bills to be introduced on the floor. Day 58, budgets have to start to be closed, and they're looking to identify where there's agreement and where there's disagreement so they can move those disagreements into debate. By day 65, bill has to pass the first committee in the first house. Any bills that don't get past their first committee by day 68 are done for the year. Day 79, they actually have to pass the floor of that first chamber. By day 89, you're beginning to resolve those budget differences, so you've identified them earlier, and now we're starting to come up with a plan. By day 103, the bills have to be through the committees in the second chamber, and then by day 109, just 11 days before the end of the session, we have finally finished the budget. Day 110, you have to be out of the second chamber, so on the way to the governor. Or on their way back to the first house to be reconciled. And then by day 115, the budget bills are actually released. And, well, they have been released. They have to actually be passed so that they could be signed. And then there is a process. There's exemptions. There's examples where things can go around most of these rules. Most of these rules can be waived in certain cases. And so this is the deadline for any of those exempt bills on day 115. Day 120, the last day of session, we call it sine die. It's Latin for without a day, meaning that there's not any longer going to be a continuation of this body. So now we're going to talk about budgeting, going back to Congress. And Nevada, again, will mirror a lot of what we see in Congress. In Congress, the budget cycle lasts for 2 fiscal years. However, they are only budgeting for 1 year. They start their fiscal year October and it ends in September. The 4 phases are planning, review, release, and appropriations. So the planning phase begins at the beginning of the fiscal year. Agencies begin planning for a budget. At the same time, the President's Budget Office, known as the Office of Management and Budget, is starting to think about what kind of changes and priorities the President wants to make. So the agencies will kind of plan to do what they've been doing. Business as usual. OMB's job will be to tell them where that needs to change. That's the review part. At the beginning of the second fiscal year, so now we've gone October to September. We're starting the next October. The final agency budget requests for the following fiscal year, so for a year from then, are submitted to OMB. And then in February, the President's budget is released and communicated to Congress. This is typically right around or soon after the State of the Union address. So then the process goes to Congress. Now, it's often said that the President's budget is a messaging document. Depending on the relationship of the President and Congress, the Congress may choose to largely follow the President's budget and adopt it, or they may not even open it and look at it. They may already have their own priorities. So it really just depends on that dynamic, how this process plays out. But where it plays out is in the House and Senate budget committees. The first thing that they do is they get together and they have to agree on a budget resolution. This is also known as the spending cap. It's often done in conjunction with a debt limit extension. It basically sets the top line number of how much are we going to spend in this budget period. The resolution comes out of those committees and goes to a vote for the floor of both houses. And if they pass it, then it starts going into normal budgeting process. If they don't pass it, then there's a complicated process where each house passes their own resolution, makes a budget up to that number, and then they have to figure out some way to put them together at the end. Those don't usually come out very pretty. Once the top line numbers are agreed, the House and Senate Appropriations Committees take hold. Now, these committees each have 12 subcommittees, each subcommittee overseeing one of the appropriation bills that funds a part of the government. And so it's always funded in 12 parts. These committees are specialized as to what their policy domain is, and often they'll sit on the policy committee that is associated with the spending appropriated by that subcommittee. I think we said that. So these 12 appropriation bills, it is important to note that they're subject to Senate filibuster. So if they did not get through budget reconciliation process, then these do need 60 votes on the Senate floor. So if any or all of the bills are not passed by the end of the fiscal year on September 30th, the only way to keep government open is called a continuing resolution. This basically says we're going to spend at the same rate and in the same proportion that we were spending in the last budget going forward until a set time. That set time kind of varies, but it's often several. You'll often see several continuing resolutions. The first one might be an optimistic one, move it forward a couple weeks. Then they usually realize they've got more trouble than they thought, and they'll move it forward to Thanksgiving or Christmas. They might move it forward to the new year. They might be looking at election, and they might be expecting to not be in control of Congress, so they might want to move it forward even more into the spring, or maybe they are taking control of Congress, so they want to move it forward until the spring after they'll have some time to debate their own priorities. And in a presidential election year, it's not unheard of to just go ahead and not agree on a budget for the entire year to move it forward until past the election, or even until past that next president takes office. Another thing that you'll see here is that you can put all or some of these bills together into what's called an omnibus bill. And the benefit of an omnibus bill is that it can be kind of the only game in town. And so if there's areas of disagreement, you might be able to get people to vote for the part of the bill that they want, even though they're opposed to another part of the bill, because that's the only way that the government's going to be funded. So in Nevada, the budget process is largely the same. You're still coming across the executive's proposed budget, going to the appropriators in the legislature. The key difference is that the state has a 2-year budget. Because they only meet every 2 years, they have to budget for the next 2 years. So the planning phase begins with the governor communicating priorities to the agency heads, just like the president does. The governor has an office equivalent to OMB called the Budget Division. And then, again, in a similar manner, those plans are reconciled between the agency heads and the priority of the governor. The extra wrinkle that Nevada adds is that division of the legislature, again in this professional legislative council bureau, does get to look over that budget and make sure that it's legal by their understanding, that it's within the agreed upon amounts, and so on. The budget is released in Nevada typically with the governor's State of the State address about 2 weeks before the beginning of session in mid-January. And then the appropriation path, there's a fewer committees that it has to go through, but essentially there's money committees. In Nevada is the Assembly Ways and Means Committee and the Senate Finance Committee. The appropriation bills go, the budget bills we normally call them, go through those committees to the floors of each house, across to the other chambers committees, to the floors of those houses, and then to the governor. A note about fiscal notes. So any bill expected to increased expenditures or revenues by more than $2,000 requires a fiscal note to be prepared by the affected agency. This is the agency who's either getting an increase in their budget or decrease. The fiscal note specifies how much the proposal will cost. And this can be a big barrier. If your policy proposal is not already included in the governor's budget or not already planned for by both the money committees and the leadership that's going to have to pass budgets on the floor, a fiscal note can be a bill killer. There's a maximum amount of money to be spent, and both the legislature's budget and the governor's budget already account for all that money. So if you're proposing to spend more, you're going to have to find where you're going to get it. That top line number in Nevada comes from an entity called the Economic Forum. This is a feature that the federal government does not have, because the federal government does not have to, they don't have a limit on the top line of money that they're going to spend. They can always print more if they decide that's prudent, and they can always borrow more if they decide that's prudent. In Nevada, we're not able to do either of those, and so we convened the Economic Forum, which is made up of 5 members, considered financial and economic experts from the private sector, often from the gaming, mining industries, often from the banking industry. The governor appoints 3 of those 5, and then 1 each by the Assembly and the Senate. So the forum gets together periodically throughout the year, and not very regularly. It's more backloaded, so it kind of starts towards the end of the year. They might have several meetings, and then often a couple in the spring as well, and then they won't meet again until the following fall. But they're taking in macroeconomic information. They're taking in sales tax, actual receipts, and getting other folks, consultants and state agencies to make forecasts based on those. And so they're going to take all that information, all those forecasts, and they're going to agree on a common forecast. And that'll be the amount of money that the legislature is allowed to spend. That's binding on the legislature's budget. The legislature is not allowed to spend any more than the economic forecast prescribes. So as a public health or health professional, why should you be involved in government, and what are you going to do to be involved in government? I hope we've explained why to be involved in government and a little bit about what the government is that you could be involved in. So here's the how. The key point of this is, as a state employee or employee of a nonprofit with a government grant, you may be restricted in the communications you're allowed to have with elected officials. The key distinction here is between education and lobbying. So lobbying is when you ask, please pass this bill, vote for this, or vote for this candidate. That's lobbying, and it cannot be done in your capacity as a state employee or while you are being paid by the grant, federal grant. What you can do is educate. So you can educate lawmakers on why an issue is important, your forecast of the outcome of a piece of legislation, good or bad, and point out the unintended consequences. You can't say, vote for Affordable Care Act repeal. You can say, if you repeal the Affordable Care Act, then premiums may go down in the individual market. The distinction is when you say, vote for this, and you have something to point to. So in Nevada, we're very lucky to have accessible representation. There's 2 senators and 4 representatives. You're represented by at least the 2 senators and at least 1 representative. And if you represent an organization that has multiple sites, you could be a constituent of multiple representatives. If you're statewide, you could be a constituent of all the representatives. If your representative is not interested in your issue, it's important to know that you can go next door. You can find a representative in your state or out of your state that is interested in your issue, is interested in your constituents. And so if you have not started that at all, a good place to get started is congress.gov. You can find out who your senators or representatives are. You can also learn a lot more about the process there. Within the legislature, your citizen legislators are even more accessible. They live at home in your district for almost all of the time, except for the 120 days every 2 years. You can have meetings with them. They will take your calls. They will take your emails. They want to hear from you because they don't have time outside their normal lives or within the limits of their terms to become experts on your issue. They're only there for a maximum of 12 years, and so they're not going to be a subject matter expert like you are, bringing your careers worth of knowledge. So getting to be known as that knowledgeable expert can get you a lot of attention from your legislator, because they might want to rely on you for what their opinion should be about the area of your expertise. You can and should follow along with your government at their award-winning website. It'll tell you who your legislators are, how to contact them. You can watch recorded and live videos of the hearings and the floor sessions. There's an option to weigh in your opinion on a bill. Remember, that's over the line of lobbying, so don't do that on your company time, company phone, company computer, etc. And you can also set up, if there's legislation that you're interested in, you can track a certain number of them and be alerted when there's any developments on that. The website is here. And then my soapbox. So I believe we have a special responsibility as a member of the medical public health community. You will encounter patients and members of the public whose suffering could be alleviated with a policy change, whether at a societal or program level. And really, some believe that you would have a responsibility to address that concern where you had the ability to perceive it and the resources to alleviate it. You're the expert. You know more than the policymakers about how these policies affect your patients. So be vocal about that. And then it can be very rewarding. I believe it's very rewarding to heal an individual. But passing a policy or informing a policy that has the ability to impact thousands, millions, that can be very rewarding as well. And then it's also important to demonstrate civic participation for your patients. For many underserved communities, a big part of what they're missing, a big part of why their community is underserved, is because they have not been successful at getting their representatives to represent their needs. And so demonstrating that, teaching those people, our patients, how to become that advocate, to speak up, to say, I'm the expert in why this policy is not working here. That can be an important and empowering and even health-producing outcome for some patients. Thanks very much for joining me today, and please feel free to contact me if you have any questions.